Good afternoon. Oh, it's him again. I'm going to take a very different approach for this presentation than I did this morning. And I'm really focused on the questions that Carolyn and I guess the organizers sent me. So I have about 5 slides where I'm just going to give you a little bit of context for the answers that I give to the questions in the last 2 slides, but it's only a small set and it shouldn't take me long to get through this. So I don't mean to disparage the mighty Colorado River by calling it a stream, but here's a little riddle for you. When is a data stream not a data stream? When it's health data. Specifically, the health data in electronic health records of these health systems. That is a lot of data. Look over there. All those data over there is the, what's this thing behind the Hoover Dam? What's the name of that? Lake Mead? Lake Mead? A lot of data over there, very deep, a lot of data, but a little trickle comes out over here. You need IRB approval, you need a data pull by the IT group, you need data transfer to me by secure FTP, you need data cleaning, variable creation, what we call the phenotyping of patients, data merging, linking to environmental metrics. The creation of the environmental metrics is totally separate. We heard a little bit about that from Francesca. And then data analysis, which is done separately, and it's very computationally intensive. So yeah, there's a lot of data here, but it's not a data stream in the sense that it's not a regular trickle. It is behind big, strong walls, and you have to try really hard to get access to it. Now, these data are very different than the data that we heard about from Francesca. These are individual encounters with individual patients, with their date of birth, with their home address, with everything that happened in the inpatient, outpatient, emergency settings, their procedures, their laboratories, their prescriptions, their telephone contact with the health system. Anything that you could imagine a health system does with its patients are behind that dam in Lake Mead. So there's a lot of complexity in using electronic health record data. And so I just want to think through some of these issues with that natural history of diabetes plot that I showed you this morning. And so in the natural history of diabetes, we start with people who are healthy, and then they get some pre-diabetic condition, and then they're eventually diagnosed with diabetes, and then they eventually, if they're not well managed, can have strokes and heart attacks and kidney failure. This slide illustrates the challenges of EHR data, but also the great utility of EHR data. So as I mentioned this morning, in our traditional approaches to epidemiology in the past, I could do a study of diabetics. I could come up with some case definition for a diabetic, and I could identify these folks in the population, recruit them, bring them into a study, measure stuff on them. But with electronic health record data, I know when they develop diabetes. I can look for hemoglobin A1C levels, I can look for fasting blood sugars, I can look for ICD-9 codes, but then I know what happened to them the 3, 4, 5, 6, 7, 8, 9, 10 years before they developed diabetes. So it's a really powerful way to study patients and look at the trajectories of health over time and study people, like Alzheimer's disease is a great example. How are you going to find those people? And if you study them when you diagnose them, is it too late to estimate exposure to things that are interesting, either with biologic things, which may have changed as the disease process progresses? But in this, if you can set up a biobank and put stuff in the freezer, you can clearly diagnose people and then look back for what they had at the relevant time. Now, when we did this study of the abandoned coal mines, we had about 20,000 diabetics, and we looked at our data, and we found all sorts of strange things in the data. We found a good proportion of patients had been treated for diabetes before they ever had an ICD-9 code for diabetes. So when did they develop the diabetes? And who should you study? So this just gives you a little bit of the relationship between these, but that was a downside to the data, and when you use secondary data like this, there is a lot of stuff that you have to interpret, but it's also a power of the data because I can use a lot of clues about patients to figure out what point in time do I want to study them. So thinking about that, using electronic health record data that is longitudinal, how do we know when a patient has diabetes? When does observation of the patient begin? With claims data, I have their enrollment date in the health plan. With electronic health record data, I don't know for sure if, again, they're in the plan, they have a primary care provider, they're under observation and not being seen, or that is, they're healthy, or they've dropped out. They can enter and leave this cohort at any time. There are lots of questions about when the patient's diabetes began. Is it when an ICD-9 code appears in the record? Is it when their hemoglobin A1C, the glycosylated hemoglobin that occurs as blood sugars go up, they covalently bind to the protein hemoglobin? Is it when that gets elevated? Is it when there's a fasting blood sugar above a certain level? Can you tell a fasting blood sugar from a random sugar in electronic health record data? All sorts of complexities like that. How do you distinguish type 1 from type 2? Would that be important? How would you do that with electronic health record data? Can you do that based on age? We used to do it based on age, right? It was all type 1 before the age of 30, but now 12-year-olds are getting type 2. So there's a lot of complexity with that. What does it mean if the hemoglobin A1C level exists or diabetes treatment began before any ICD-9 code for diabetes was present in the record? How do you interpret those kinds of data? So lots of questions and lots of expertise needed to make decisions about how to decide when a patient has the condition of interest. How do we define diabetes severity? And how do we avoid in studying diabetes what's called confounding by indication? In observational studies of drug effects, drugs are not assigned randomly. The indication for treatment may be related to the risk of future health outcomes. So for a lot of pharmacoepidemiology and cost-effectiveness research, using these kinds of data, you have to be careful to avoid this problem. So a lot of the questions that I was asked, I just want to give a little bit of background to the efforts that have been made in the HMO research network to try to make these data more accessible and usable to a larger community. And the effort that really was focused on that was called the NIH Research Collaboratory. And in this NIH HMO-RN Collaboratory, in July of 2010, there was a discussion about trying to do this funded by the NIH. And the stated purpose was to enhance and strengthen a research platform to accelerate large epidemiology studies, pragmatic clinical trials, and electronic health record-enabled healthcare delivery research by leveraging HMO-RN's scientific data and operational infrastructure. So a lot of what today has been all about, making this data stream more useful for research. So there was a limited competition U54 RFP that was released in February of 11, but then it was changed, and ultimately an award was given to the Duke Clinical Research Institute, $9 million from NIH, and the goal of that changed. In their September of 12 press release, they said the goal of this collaboratory was to involve clinicians and patients in the design and interpretation of trials, provide the education needed to enhance the value of their participation, and use the data collected during healthcare delivery as the core data source for the full spectrum of clinical research from registries to observational studies, et cetera. So it's slightly changed, and nobody knows exactly why that happened, but that I think was a big opportunity lost because those 19 institutions with 20 million patients, in the first one, I think could have produced something that was broadly, systematically useful. And in this case, I think only 2 HMO-RN members are working with Duke on this. Now, as part of the first one, not what was funded, but as part of the first one, a big goal of that was to develop a virtual data warehouse, the VDW. The objectives of the VDW initiative were to improve data quality, enable cross-site and cross-project synergies, balance site, project, and network level priorities, reduce the preparatory work needed to assemble cohorts, count events, capture exposure and comorbidity data, all in support of an array of different types of research studies. Exactly the stuff we're talking about today would have been a good thing to do, but that was not what was funded. Now, the VDW is an ongoing effort of many HMO-RN members now, but it is not funded by anybody. It is limping along, and this bolus of NIH money did not come down. But the efforts that are going on is that most HMO-RN members have an internal website that has metadata about their VDW. You can see some of the details there. The HMO-RN has developed guidelines and policies to facilitate research. Control of that resides at each member site. There are efforts to write programs to extract and convert variables stored in legacy information systems to common standards, test standardized data for consistency and accuracy, standardize methods by providing macros and programs, etc. The HMO-RN website has a whole manual on how to develop research with them, guidelines, a lot of information on all of this, but that is limping along because the NIH money that was given to Duke is not about this VDW. So the VDW is not a centralized data warehouse. It consists of parallel identical databases at each HMO-RN site to facilitate merging across sites. It's not currently an analytic data set, but it is much easier to use to create one than the way I've been doing it. And as of March 2011, the HMO-RN members collaborating on the VDW have agreed that this is what will be in their VDW. So you can get a sense for the kinds of variables that are in there now. And I can bring this back if you guys have any questions about that. So this just illustrates the complexity. So I told you this morning a bit about the complexity of using data from just Geisinger. What happens if you wanted to do data from multiple sites? Well, this is a paper by Kahn in Medical Care just last year. And this looks at serum fasting glucose tests per 1,000 patients in 7 HMO-RN sites. And you see huge variation across sites in the prevalence of testing. You also see big temporal variations in the site. So something happened here. And down here, there's an explanation for why all these things occurred. But it shows that with a secondary data source like this, without a lot of standard protocols for what the definition of these various measures means, when you merge the glucose data across sites, you're going to have to spend a lot of time on assessing data quality as the first step in multi-site studies. Now, a lot of you guys know that already, but it's really, really important because if you dove into these data right away, you would conclude a lot of inaccurate things because clearly there are different practices going on at these various sites. Okay, so finally, these are the questions I was asked. So what kind of data stream am I addressing? The health data stream, and specifically the health data stream from electronic health records. As I said this morning, at Geisinger, that represents 400,000 primary care patients, hundreds of millions of records, many kinds of health data. Anything you can imagine is generated in a clinical encounter, they can get access to, and I could try to get access to. What is the current status of data collection and archiving? Most patient health information will be collected electronically in the coming years. ERA and healthcare reform have said that. So my wife is a physician in private practice, and I haven't seen her much the past year. She's working 14 hours a day because she had to put an electronic health record in her office. It's required, and it's a tremendous learning curve, but that's a whole set of new data that we could eventually, hopefully, link. All patient data will be electronic in the coming years. There's no single repository for U.S. health data the way I've been talking about it, as opposed to the way Francesca did. Most of the large health systems most often use programs such as Epic. They have to export the data from Epic to a data warehouse for more easy access, like the virtual data warehouse, the VDW. And then they have to export it from there to researchers for analysis. So lots of steps, lots of people involved. There's no centralized warehouse. There are mechanisms for gaining access. There is no centralized catalog. So there's a big learning curve and a big investment from all of us if we want to use these data. Concerning the non-technical aspects of sharing, these data are not public. They can be accessed after agreements are in place, most often in collaborative research relationships. There is no routine sharing. Creating a single national repository of EHR data would be a daunting task. It is way above any of our pay grades. It's way above any of our conceptual capabilities, I think. It is something that others are going to have to deal with. A single national repository of EHR data would be a goal, would be a tremendous asset, but I think we're a long time from there. Concerning standardization and description of the data, there are many types of data: dates, encounters, diagnoses, lots of different kinds of codes, lots of different kinds of laboratory tests with results, procedure test codes, sometimes with results, those are, as opposed to laboratory tests, things like lipids and glucose, things that you might get from blood. Procedures are more like cardiac catheterizations, pulmonary function tests that all exist, but not always in the main data warehouse. There's also physician orders, medications, imaging data. You mentioned it. We have all this digital imaging data. We just need a way to sort of get it and analyze it. There is a lot of variation across providers, clinics, and health systems. In electronic health records at Geisinger, the clinician is with the patient with a screen, and there are pull-down menus for documenting what happened in that encounter. And whether you pull down and land on the correct ICD-9 code or not is a question. And ICD-9 codes are used for a variety of reasons. One is, that is the diagnosis. Two is, because I wanted to justify the test I just ordered. Three, because I want to justify the charge for the visit that I just used. So there's a lot of reasons for ICD-9 codes, and using ICD-9 codes for this research by themselves is probably not adequate. That's why having all the other data is much more useful. A diabetes code might not be a patient with diabetes, but a diabetes code in a patient who's on an oral hypoglycemic, who's had multiple hemoglobin A1C levels over time, now that is a diabetic patient. There's not yet many ontology or metadata standards. Text searching is necessary, and there's a lot of interest in the HMO Research Network for natural language processing. Because those of you who are physicians know that there's a big part of the medical record called the history of present illness. And the history of present illness is a couple of paragraphs of text. And there's a lot of very important context in there, and lots of people are trying to use natural language processing to figure out what that piece of the medical record means. Concerning movement and ability to combine with other data, these health data are for individual patients. Individual patients cannot be directly linked to family members, as I talked this morning, but there are ways that we're trying to work around that. Health data can be linked to other data by location, generally residential address, and date. So, as I mentioned this morning, most of our analysis in environmental epi is looking at exposures in space and time. In general, approaches to the analysis of EHR data are on a study-by-study basis. Data have to be accessed, exported, used to create analytic variables, merged with other data, and then analyzed. EPIC, the data, program in which the electronic health record is organized, has some analysis tools, but in general, we export the data. Most of the HMORN members who do research have the clinical encounter in EPIC. They have the virtual data warehouse as a way station, and then you use that to export to researchers for the work. Finally, what are the integration challenges, let's say? So as long as other data have meaning in space and time, there should not be obstacles to integration. So if I want to do epidemiology, and I can use a variety of methods to develop exposure estimates that I can capture spatial and temporal variability, then you can do those kinds of studies very easily. If you want to do fancier stuff on exposure and dose assessment, there are ways to use the big stream. There's another stream in health systems, and that's the stream of discarded blood specimens. And so the stream of discarded blood specimens, Geisinger is trying to collect. Right now, they're using it for genetics, but we could use it for exposure and dose estimates if you wanted to. It wouldn't be hard to sort of, they have a big centralized laboratory that gets all the blood specimens from their 40 clinics and 4 hospitals, and if we wanted to grab discarded blood specimens, could do it. Would have to get approval, would have to get IRB approval, would have to set up a system, but it's doable. Finally, in studies using these kinds of data, I want to acknowledge that you don't always get what you actually want. And so with all secondary data streams, you have to sort of think about what are the questions that you can answer with the data, not what is the question you would like to answer, because you don't always have that luxury. And certainly for the exposure and dose estimates, we're using surrogates for what we would really care about. But I think there's a lot of opportunity to improve upon that in the future. Thanks.